So welcome. Let's have a chat about endocarditis. So I've got two case presentations to start off with rather than my usual ECG of the week. So if anybody joins late, they can join halfway through one of these fairly short cases. Then I'm going to talk a bit about when to suspect endocarditis, and I will talk about how to diagnose it as well as the management of it. So first case, this is a Mr. A, and he's a 72-year-old gentleman, and he's presenting with 6 months of feeling generally rubbish, with back pain and night sweats, and some new exertional breathlessness, loss of appetite and joint pain. Nothing particularly in the past medical history, medication or social history, normally a fairly independent, well, 72-year-old gentleman. On examination, he's slightly pyrexial, or slightly. It wouldn't actually register as a fever, would it? But it's borderline. He's not particularly tachycardic. Blood pressure is fairly typical for a patient that you might be seeing and might be a bit stressed about what's going on with them. JVP's normal height at 3 centimeters, but he's got some heart murmurs that you weren't expecting to hear. Chest is clear and he has 4 splinter hemorrhages. These are the blood test results. You can see that I've given him a normal white cell count, borderline raised neutrophils, a slightly high CRP. So this is a fairly typical presentation of endocarditis. There are different types of presentation, and patients can present with very severe sepsis, very acutely unwell, or they can present a bit more subacutely like this. And they can also present with a much more indolent sort of course. And it depends very much on which bug is causing the endocarditis. And does anybody want to make any comments about this presentation of this case so far? There are obviously lots of other conditions that could be considered here, and the real clue is that we've heard the heart murmurs. Does anybody want to say anything about that? You could point out to me that a 2/6 ejection systolic murmur is the sort of murmur that lots of people might not hear. It's a definitely audible murmur, but you're still wanting to be listening in fairly optimal conditions to hear that. It's not like it's a 4/6 murmur. And the same for the diastolic murmur. So you could very easily overlook these cardiac features, and you might then treat for a chest infection. Splinter hemorrhages, we'll come on later on to splinter hemorrhages, but 4 splinter hemorrhages would be significant. So this is a fairly indolent presentation, and there are lots of bugs which cause endocarditis. I really wouldn't expect you to memorize them, but you perhaps be aware that the common ones are things like Staph aureus and the viridans streptococci, which are the commensals which live in your mouth. And Staph aureus tends to present with patients who are very poorly, who've become acutely unwell. So Staph aureus doesn't present indolently when it's causing endocarditis. It tends to make patients very, very poorly with rapidly progressive damage to their heart valves. So that's a serious condition whenever you see Staph aureus endocarditis. Most of these others can present very aggressively, but are generally presenting in a sort of a middle way, like the gentleman I've just described, where they would be unwell and septic, but they might not be very acutely showing signs of septic shock, for example. Coagulized negative staphylococci are the skin commensals, so Staph epidermidis. And those tend to present very indolently. So you tend to have somebody who might fever, might be generally a bit of malaise. So these patients cannot immediately shout endocarditis to you. And usually these are patients who've had a procedure. So they've got an artificial valve or a pacemaker in, or there's something that has specifically seeded the relatively indolent bacteria onto the valve. And what can happen is you get an equilibrium between the immune system attacking and getting rid of the coagulase negative staph and it being protected from the immune system by the artificial material. So that equilibrium can last for years with the patient appearing not to become unwell, but then at some point in the future, for whatever reason, the staph epidermidis gets the upper hand and starts to cause sepsis and starts to cause damage. So that can present years after a pacemaker or a valve implant. I'm going to show you some echo pictures. So this is just to orientate you. If you imagine the patient's heart in their chest, with obviously chest around them. This parasternal views that we take from the sternum and we slice through the heart a bit like this. So you get to see the right ventricle at the top, the left ventricle, mitral valve with the papillary muscles, left atrium and aortic root, aortic valve. We also can take a 4-chamber view, which is just simply pointing the probe up and looking upwards at the heart, and we tend to see 4 chambers there. That's the one that is what you expect to see and is nice and straightforward to understand. We can also take slices through the heart at lots of different positions in the short axis, and rather than seeing the heart as a sort of a V shape or a U shape, we see it more like a donut. And in these views, the right ventricle always looks like it's tacked on like an afterthought because the left ventricle has so much more work to do. So the 90% of the muscle mass of the heart is the left ventricle. So now that you know what you're looking at, and this is a parasternal view of the gentleman that I've just presented with this malaise and increasing breathlessness and losing weight, not being quite right, I would say that's a fairly indolent presentation. You might expect something like a staph epidermidis. Potentially, it could possibly be one of the others, but it would be very unlikely to be staph aureus. So what does this echocardiogram show? Yep, so we've got the left atrium here, mitral valve here, the papillary muscles here, the intraventricular septum, right ventricular outflow tract, and the aortic root, aortic valve. So can you see anything there that doesn't look quite right? And this is why we talk about the sensitivity and specificity of transthoracic echo versus transesophageal echo. So if you can have good transthoracic views, you by and large will be able to see something. Where you don't have good views, then you can't exclude it. And so actually, in patients who've got endocarditis, a transthoracic echo is usually, assuming the views are halfway reasonable, is usually a pretty good rule in or rule out test. It's where you have poor views that the problem comes. And can you see here, there looks to be something on this anterior mitral valve leaflet. And can you see how it seems to flick forwards? You see it flicking forwards? It looks as if it's more than just the valve tip that's moving there as the valve opens. And this valve, can you see this is nice and thin valve structure here? This valve doesn't look quite right. It looks a bit thicker than it should. And there might be something, there might not be something. It's very hard to tell. And so what we can do is zoom in. And if I zoom in, can you see that this thing bobbling around here doesn't look right? So that is a small vegetation on the mitral valve. And again, if we zoom in on the aortic valve, is there something here that shouldn't be there? It's very hard to tell. Maybe that's just an artifact, but the valve certainly looks thicker than it should be. We look at the heart from lots of different angles. I've moved round to a 4-chamber view now. And can you see that, again, there looks to be something flicking to and from as the valve opens and closes over here? So this is what the echo technician is trying to look for, and you can imagine if you have limited views that it can become impossible to really say for sure. Can you see over here? We can't see the aortic valve. The angle of the echo, it takes a picture about a centimeter thick, which is just sort of made into a flat 2D image. But that centimeter thick sort of wedge that we're looking at the heart with is directed below the level of the aortic valve. So we can't see the valve, but can you see there's something here that appears during diastole and disappears during systole, which would be very suspicious for a vegetation. And again, we can zoom in, and if I zoom in and I manage to get the picture better, can you see now that actually we can really convince ourselves that there's something jumping around? We can look and see if there's any leaking. There's an orange puff. Orange goes towards the cursor. Blue goes away, so we can see the puff of orange as the atrium empties into the ventricle. There's not a lot of mitral regurgitation here, so although there's a vegetation, it doesn't look to be damaging the valve. And we can look at the aortic valve as well. And it certainly looks thickened. We can see there's something moving around that shouldn't be there. And if we put color across it, can you see that there's this time it's orange because orange is going up towards the cursor and the aortic regurgitation is going up towards the top of the screen. Can you see this quite thick jet of aortic regurgitation? So this aortic valve is being significantly damaged. So that's the sort of thing that they're looking for with transthoracic images, and that's why they can be limited. And why do we do a TOE? This is actually a different patient, but you can see how much more clear the views are. And this is because the probe is in the throat and the lungs aren't in the way, and there's no intervening tissue. The thing about ultrasound is that it takes time for the sound, which moves at about 400 meters per second in liquid, and tissues are basically liquid. So about 400 meters per second, but it's still got to move 5 centimeters, 10 centimeters, maybe 20 centimeters in and out in order for us to get the picture. And so our the number of frames per second is limited by that speed, and the type of the probe and the frequency of the sound is affected by how deeply it needs to penetrate. So we can get much better pictures when we're right up against the heart in the esophagus. And you can see the mitral valve here. There's a vegetation here coming in and out of shot on the aortic valve. You can't really obviously see a vegetation on the mitral valve, but when we put a bit of color on, can you see there's a bit of yellow coming through the middle of the valve, as well as a leak here through the main opening in the valve? And if we then spin round 90 degrees and look at that from another angle, can you see that there's this puff going across the valve is actually very clear? So the endocarditis here has punched a hole through the middle of the valve. So it allows us to look at just with so much more detail at what's going on. And an echo can be good to rule it in, but if we want to look at how things have changed over a month of antibiotics, or we want to look for an aortic root abscess, then transesophageal echocardiography is superior. So we certainly want to do a transthoracic echo, but most patients with endocarditis will need a TOE at some point. Any questions so far? Please ask them as we go along. So we've got another gentleman. This is another type of patient presenting with endocarditis. And this time it's a patient who's had a very, very torrid time over the years with endocarditis. He started off with endocarditis in 1988 and had to have an aortic valve replacement because it damaged the valve. And then he had further endocarditis in July last year and again in November last year. And he's been known to have a little bit of a leak around the valve. So I'll show you a picture of a valve in a minute, but The valve is stitched in to the aortic root, and the valve has a sewing ring around it. So it always limits the size of the valve compared to the native valve, because your native valve doesn't have a sewing ring, it just is part of the aorta. But the sewing ring means that the valve is slightly smaller inside, because the sewing ring, and it's inside the sewing ring. Now, the way that sewing ring is stitched in, if that's not perfectly stitched, you can get a leak around it. So you often do see a little bit of leaking going around the outside of the valve, which is what this means. And it's important to know that, because if that's new, then that might be a feature of endocarditis eating away at the sewing ring and loosening the valve. So this time round, this patient is presenting with fever and rigors and severe malaise, and it's only been going on for about 48 hours, and it's getting rapidly worse, and he's very short of breath. So this is a very acute presentation, which could be any bug, but it does make you wonder about Staph aureus, and Staph aureus often doesn't respond well to antibiotics. So that should always give you great concern the patient is going to fail medical treatment and need urgent surgery. He's got a high temperature, tachycardic. His blood pressure is okay, which is good news. Again, has murmurs, but we wouldn't really know for sure what murmurs we would expect to hear, given his history. 3 splinter hemorrhages and an Osler's node on his nose. So I'll come on to what an Osler's node is a bit later on. Very, very rarely see Osler's nodes or Janeway lesions, or the things other than splinter hemorrhages are really pretty rare in endocarditis, but important to spot if they are there. So what does the valve look like? You've got to imagine yourself in the heart, looking up at the aortic valve, ready to be ejected as the left ventricle pumps. They always show pictures of valves sort of upside down to the way round you might think them to be. So imagine the heart up here or beneath this valve. And as the heart pumps, your blood cells go through the valve. And these tilting discs will tilt upwards and let the blood go through. But then as the pressure of blood comes back, that causes these leaflets to close. Now, so that's blood going through rather than closing the valve. Now, these work beautifully, but as I've said, this sewing ring has to be stitched inside the aorta, so that limits the size of the valve compared to nature. And if you have a small aortic root to start off with, because you're a small person, that effect is much more marked. You can imagine if this loses you 2.5 millimeters or so, and your aortic root is 2.4 centimeters, then actually that's relatively small proportion of it. But if your aortic root is only 1.7 centimeters, suddenly it becomes a much larger proportion of it. So it can be very important to put the right size aortic root into the aorta, but it's no small feat to increase the size of the aortic root. So you end up with risks of getting patient prosthetic mismatch, that you put a valve that's too small for the patient in, but that may be because it was very hard to fit anything bigger in, and would have been a much more major operation with more major risks. So this is an echo of this gentleman who's presenting acutely unwell with fever. And does anybody want to comment on this for me? So this is the parasternal long axis view again, like the first shot that I showed. And we've got the left atrium here, got the mitral valve, papillary muscles, left ventricle, right ventricular outflow tract, aortic root. And here we have the aortic valve, the metallic aortic valve. And can you see that the acoustic shadowing, we call it? And that's because sound conducts far, far faster in metal than it does in liquid, something like 2000 meters per second rather than the 400 meters per second. And that means that you just can't see it because the computer can't process it. You know, if the whole body was metal, then you could, but you can't cope with the interface change, and that's why we can't cope with lungs, because sound travels about 80 meters per second in air. So it's that interface. You need it all to be constant. Thank you, Al. So you said that it seems the metal not moving. So it's a good suggestion, and it really here is very hard to say if the metal, how the metal is moving. But can you see how this acoustic shadowing is coming and going? And that's the effect of the valve. If when it's in this this open position, these are sort of shielding. Those are creating the acoustic shadowing. The sort of the footprint of the valve on the angle that we're looking at it on the side is bigger than when it's closed. So that's why when it's closed, these leaflets, or when it's open, sorry, these leaflets are sticking up further and they're creating the acoustic shadowing. So we do know they're opening, but we can't see the extent to which they're opening. If I zoom in, can you see here this dark bit that's around the valve? There shouldn't be a dark bit there. And if I put color on it, can you see in that bit that was dark there, there looks to be some color. And this area that's got color coming through it, that is an abscess around the valve. And can you see how this valve is rocking forwards and backwards in this position? And you can imagine, and as it rocks, every time it rocks, it's helping to loosen the stitches that are holding it in place. So this, when we see a rocking valve and describe a rocking valve on echo, that is very concerning. And it's very concerning that we've got this big jet of aortic regurgitation coming through there, because that is a strong sign that this patient has developed endocarditis, because it's a change from previously when this was only mild leak. But also the rocking valve could loosen the stitches further, and that leak could get worse very rapidly, and that could make the patient very unwell very fast, and the valve can even dislodge entirely, and you can end up with torrential mitral aortic regurgitation. So a rocking valve is a surgical emergency. They might be okay for a few days. I've had patients that have survived for a month into discharge who've had rocking valves that were simply not fit for redo surgery. But the danger here of the patient becoming acutely well immediately is high, and so you need to seek immediate senior support if you see a rocking valve. Other features that you'd look for to ask for immediate support would be if the vegetation was very large. So large vegetations rocking valves, make sure that you get immediate support, because they might need emergency surgery. So those are my cases. Let's talk a bit more about endocarditis. And I like the words of William Osler from 1885, who said that few diseases present greater difficulties in the way of diagnosis than malignant endocarditis, difficulties which in many cases are practically insurmountable. It is no disparagement to the many skilled physicians who has put their cases upon record to say that in fully one half the diagnosis was made post-mortem. Well, I hope we don't make all of our diagnoses post-mortem now, but it remains very, very challenging. Why was he so bothered about the diagnosis here rather than the treatment? Anybody know why he's so bothered about diagnosing it before the post-mortem? It's of course, because there was no treatment for endocarditis back in 1885. Antibiotics hadn't been discovered, so it was a diagnosis that led you to tell the patient that their treatment was entirely palliative. So it was very, very bad news back then. But it still is very, very hard to diagnose, and we'll come on to Duke's criteria in a minute. How do you manage the patient with endocarditis? Well, I've already taken you through how it presents. So it can be subacute, it can be very acute, and the differential diagnosis would be things like pneumonia, UTI, something rare called an atrial myxoma can confuse you. But the difficulty is that it's often people suspect it, and then it becomes a very hard condition to rule out, particularly in patients with metallic valves. So it's a hard condition to rule out in somebody with a malaise of unknown origin. When they've got an artificial valve, it can be very difficult to work things out. And if you are making a diagnosis of endocarditis, it's really, really important to get a culture of the bug. And so unless the patient is acutely unwell, delay and delay and delay, if you can, the antibiotics. Now, if the patient's septic or their heart valves are falling apart, then you may have no choice but to get in with antibiotics quickly. But if you can delay, it's very helpful too, because as soon as you treat a chest infection or UTI, then you won't knock out the endocarditis, but you often make it culture negative. And that makes it very much harder to make the diagnosis and harder to give appropriate antibiotics. So delay antibiotics if possible, and get at least 3 sets of blood cultures from different sites, ideally at different times, because you get a pulse of bacteria released into the bloodstream with endocarditis, and probably half an hour after that you get your fever. And so if you wait until you've got a fever and then you try and take a blood culture, often the bugs have already been cleared from the circulation. So it doesn't pay you to do cultures every time they have fevers. What you really want to do is to do 3 sets of blood cultures spaced out a few hours apart each. And that way, hopefully they'll have a fever during that time, and hopefully you'll catch them just before they get the fever, but while the bugs are still in their bloodstream. So do your best with that. But it's essential that we get 3 sets of blood cultures so that we have a chance at a diagnosis. Antibiotics, it's very much a teamwork with microbiology, what we give in terms of antibiotics. So you will need to speak to them, because you won't be able to have a code and prescribe. But rather than just giving meropenem, it might be appropriate if you're following sepsis 6 and you need to get antibiotics in fast. But if you do think it's endocarditis, it's much better to have a clear plan and discuss that with microbiology. The having made your diagnosis and started your treatment, we want to assess to see how patients respond. And we're assessing a number of different things each day when we see patients. One is to see that their fevers and malaise and their loss of appetite are settling down. It's always good when the patient is eating well and the fever is settled. That's a clear sign that they're responding. You want to assess them each day to decide, is their valve falling apart? Is it getting worse if it's already leaking? Is the murmur changing? Are they developing heart failure because of the problem with their valves? We want to look out for embolic symptoms. So you can embolize anywhere. I'll show you a graph of where it tends to go later, but they're often subclinical or occult cerebral abscesses in patients with endocarditis. So it most commonly goes to the brain, and you don't necessarily get symptoms, but you could have it to the spleen or the liver, the kidneys, even to the heart. So look out for embolic symptoms, because that would be a sign that we need to do an emergency operation. If they're starting to seed off emboli everywhere, then it needs to be removed. And to start off with, we want a daily ECG to look at the PR interval, because an aortic root abscess can form and cause the PR interval to prolong. Once they're symptomatically better, then it doesn't really need to be every day, perhaps weekly, but until you're clear that they're symptomatically responding, they need daily ECGs. They should immediately have an echocardiogram done, because you need that to help you make your diagnosis, and you need to know how bad the valves are, and you need to know if they're falling out, like the one I've just shown you. So a transthoracic echocardiogram is essential straight away in any patient with suspected endocarditis. And the problem comes that we're very often, the department's asked to do echoes in patients who are unlikely to have endocarditis to rule it out. So obviously those can't all be done immediately, because there are other pressing cases too. And virtually all patients will get a transesophageal echocardiogram. And if they're not responding to treatment, that becomes urgent because it will allow you to see an aortic root abscess. But if they are responding well to symptoms, it might be that that can happen in a few weeks. They'll usually end up with 4 to 6 weeks of antibiotics, which tend to be multiple times a day and tend to be given in hospital. So the transesophageal echocardiogram is not a big rush, providing that they are symptomatically well. You might need it to decide, are you going to have to fix the valves at the end of the admission? So if you're not sure how bad the valves are, but we'll want it to document exactly what the state of the valves are, as well as more acutely if you think there might be an aortic root abscess. Probably the biggest thing is to monitor the antibiotic doses. It is absolutely critical with these patients. They've got a high mortality rate. It's absolutely critical that they get every dose of antibiotic on time and that their gentamicin or vancomycin or other antibiotics are adjusted based on their serum levels and that those levels are done at appropriate times. And that can be a real drag. Getting a PICC line in early is really useful because that means that there won't be these gaps in drugs being given when Venflons fail and their veins have had so many Venflons put in that they're very hard to get. You can also take blood from a PICC line, so you don't want just a single lumen short peripheral line. You want a PICC line so that you can monitor bloods as well as give the antibiotics for the whole month that they're with us. And be aware that some bugs are associated with GI malignancy and need GI investigations, Streptococcus bovis being the one specifically. Good. So yes, difficult to diagnose clinically. So I will come back to that. Thank you. So let's just go through some signs first. What am I showing you here? Can anybody tell me what this hand shows? So you're welcome to say you don't know. Some sort of a response would be great. This could be an embolization, an infarct at the fingertip. It could be a Janeway lesion or an Osler's node. And do you know what the difference between a Janeway lesion and an Osler's node is? So Osler's nodes are painful, Janeway lesions aren't. So this certainly it's a pathology which would be linked to endocarditis. It's hard to tell from the picture exactly what it is. What about this one? This is clubbing that you can see in, yes, very good, Sahab. So clubbing that you can see in chronic endocarditis, not in acute, but in chronic endocarditis, or it could be associated with cyanotic congenital heart disease, which is a condition which puts you at risk of endocarditis. Now this is a Janeway lesion. You only know that because this person it's painless. It can be hard, but you're looking for basically a red blotch on the skin, or can be anywhere. I've seen one on the face. I had an Osler's node on the tip of the nose once, so it can be anywhere. But these are this circulating immune complexes can deposit and cause these lesions. What about this one? Yeah, it's a splinter hemorrhage. Does this patient need an admission? So this is my thumb, and this is a splinter hemorrhage, which I was horrified to discover that I had. But splinter hemorrhages, the person who discovered or first described them had 3 splinter hemorrhages of their own. So they said that you had to have more than 3 splinter hemorrhages for it to be a possible endocarditis. So just the one, particularly if you've got somebody who works as a carpenter and bashes their hands all the time, or does a manual job which they have reason to cause themselves to have splinter hemorrhages, it's nothing to worry about. These are the sort of splinter hemorrhages that you see in patients with endocarditis. There tend to be lots of them. So you can also get maculopapular rash. This again, it's the circulating bugs from bits of the vegetation breaking off, activating the immune system. You get the immunological phenomena. What's this called? So this is, it's a Roth spot. Very good. A Roth spot. Excellent. I've never seen one, but I live in hope. And this, I think you can fairly clearly tell me that this is a very poor quality CT head, but that has a dark patch over here, which suggests a big MCA territory infarct. So embolization to the brain. I've got a helpful arrow showing you the LAD. Can you see that this is occluded abruptly here? And that is vegetation occluding the coronary artery, causing an acute infarct. That obviously could affect any of the coronary arteries. It's unusual, but can happen. What about this? Yeah, so this is marked first degree heart block at the top. And this is a very concerning feature when you've got a patient with endocarditis, because it strongly suggests that they've got an aortic root abscess. This would be an unusually long PR interval. We normally say first degree heart block doesn't need a pacemaker, but when it gets as long as this, I'd be looking pretty hard to see if I could persuade some symptoms or a 24-hour ECG to show me signs of higher degrees of heart block, because I would expect it with this length of PR interval. And can you see beneath, I've got an example of 2-to-1 heart block. So they are at risk of getting prolonged PR interval and then going into heart block when they have aortic root abscesses. And it doesn't resolve after treatment, no. It might resolve a bit. It depends how much of this is inflammation. But the problem is that it needs surgery if you have an aortic root abscess, and usually you'll end up damaging the conduction system with your operation, removing the infected material. Can anybody tell me what this shows? So this is a 4-chamber view. And this is a patient who has a dual chamber pacemaker. Yeah, there is a large vegetation flapping around on this pacemaker lead that you can see here. So it's not on the tricuspid valve, it's touching the tricuspid valve, and maybe there is a vegetation on there itself, but you can't see that. But here it's attached to this pacemaker lead. So this is an example of a pacemaker endocarditis. And this patient actually had a scan by the department a couple of days earlier, which didn't show anything. And I saw this and thought, my goodness, told a colleague who said, I want that for my echo library, and went and scanned the patient himself, who was an imaging specialist trainee, and it had gone. And so this vegetation had formed within a week and broken off and gone into the lungs a couple of days later, within a few hours of this scan being done, without the patient having any symptoms. And so vegetations can be quite dynamic structures. And it's surprising that this amount of tissue could go into the lungs and not cause symptoms of a pulmonary embolism. But pacemaker lead endocarditis is serious, and you need to remove the pacemaker. Anybody tell me what this shows? And as a clue to go with that, you can have this image. So anybody tell me what this shows? So this is systemic lupus erythematosus, and yes, so it's endocarditis related to that, and it's called Liebman-Sachs endocarditis. So I have never seen this, but it's something that's reported. And there's also with a malignancy, you can get something called morantic endocarditis, which again I've never come across. So I said that it was very hard to diagnose endocarditis, and we use the Duke criteria for endocarditis, and this was developed back in, oh, I've not got the date of this, back in, I think it was 1992, but can you see here, they have got 204 definite episodes of endocarditis that they've had in their unit over the 7-year period here. And they are using these brand new Duke criteria to say that they're doubling the number of definitive cases to 135. So that still leaves 70 odd of these cases, definite cases of endocarditis, that are not detected by the Duke criteria, even in the paper in which the Duke criteria were proposed. And they were proposed in order to diagnose these 204 patients. So they've been tuned to be as effective as possible in this cohort that they've got. So even though they've designed it for this cohort of patients, they've still missed out on about 70 of them. Now, it's significantly better than the previous criteria, so that's good, but it's still not very good. And here, can you see that the only 7 of this 200 patient group was culture negative? Only 7. If only in our practice, virtually every single patient had positive blood cultures, that would be really, really helpful. So the reality is endocarditis has always been hard to diagnose, as William Osler says. But even using the Duke's criteria, that doesn't pick out definite episodes in at least 2/5 of cases. And probably more than that in our practice because patients don't have positive blood cultures. We've got the major criteria and positive blood cultures, typical pathogens from at least 2 separate cultures is what you need for major criteria. If you've only got 1, then it's a minor criteria. So that is incredibly important, and that's why I reiterate the need to do multiple sets of blood cultures. The other major criteria is evidence of endocarditis on echo, and again, if you've got clear views of vegetation, that's extremely helpful. But if you have a prosthetic valve, that can be really hard because trying to say what's normal and what's abnormal when somebody's got a tissue valve replacement can be much more subtle, and a TOE becomes essential in those cases. So those are the major criteria, and if you've got one of those or both of those, then you're pretty much home dry. But if you haven't, then you need all the minor criteria to be positive in order to diagnose endocarditis by the Duke's criteria. And that's extremely unlikely because it's very rare to see the vascular phenomena, the arterial embolization or Janeway. Well, embolization isn't uncommon, but seeing Janeway lesions is fairly uncommon. So we'd need a predisposition, a fever. These are the modified Duke's criteria, by the way, so they are slightly different from the original ones done. We need the microbiology evidence, the echo evidence that's not quite a major criterion. So it's very hard to get all of these and make a definite diagnosis. So Duke's criteria are not wonderfully helpful. They're very useful if we can say it's positive on the basis of Duke's criteria, but it does not rule out very well at all. Patients do embolize. It's important to get patients on antibiotics once you've made a definitive diagnosis because that does reduce the risk. But bear in mind, emboli are often asymptomatic. Where do they go? Mostly to the brain, but also to the spleen, the kidneys. Obviously, not to the lungs if it's a left-sided endocarditis, but they can go to basically anywhere in the body. So embolization, and once it's embolized, it is high risk of embolizing again. Patients can benefit from emergency surgery, and the reasons for doing so would be if the valve is being destroyed by the surgery, if we have infection which isn't responding to antibiotics. Sometimes we try changing the antibiotics, but if they're getting really poorly, then they might need to go straight for surgery. And embolization, and that would be something you'd have to argue with your surgical colleagues, because the risks versus the benefits of going in early are something we'd always be a little bit concerned about. Big vegetations are high risk, so it would be over 1.5 centimetre. Anything over a centimetre, discuss with a senior. And this is a paper from South Korea from about 10 years ago now. This is, I think, the only paper I'm aware of looking at early surgery versus late surgery. And that actually showed that there was no benefit to delaying. That patients having early surgery did just as well as late surgery. In fact, they did slightly better because there was less embolization. And there was no signal of recurrent endocarditis in the early surgery group. 6% at 3 months in the early surgery group versus 28% in patients given a month of antibiotics before surgery group. So no suggestion that doing early surgery was an issue with reinfection, but this is one small study from one centre, and it only looked at about 80 patients. So we still tend to try and clean the valve as much as possible with antibiotics before we go for surgery. This is what vegetations look like. They are a mixture of blood clot, platelets, thrombin, and bacteria. And you can imagine how disorganized and soft some of these vegetations are and why they might break up and cause embolization. We don't anticoagulate patients with endocarditis. But yeah, there is a lot of blood clot within a vegetation. One other thing I wanted to say is antibiotic prophylaxis, because this is quite a contentious issue. And in 2016, NICE guidelines changed so that they didn't routinely recommend antibiotic prophylaxis unless patients were at extremely high risk of endocarditis. And the thinking was that there's a risk of antibiotic reaction to, you could get anaphylaxis being given a dose of amoxicillin. The standard antibiotic prophylaxis tends to be about 3 grams of amoxicillin. They also were concerned about antibiotic resistance being introduced, and they said things like every time you brush your teeth, you introduce bacteria into your circulation. So, you know, is doing an OGD or a dental procedure, is that really necessary if you're getting antibiotics into your system every time you brush your teeth? But other guidelines elsewhere are more generous in their giving of antibiotics. And if we look at what happened when we when NICE changed these views, you can see that we follow NICE guidelines quite thoroughly, quite effectively, and the prescribing of antibiotics really fell off a cliff in response to that. But if we look at the incidence of endocarditis, you can see that from that time point forwards, it has been increasing. And it does seem that we see that. And so I do tend to be more generous in prescribing antibiotics if the patient has a previous valve replacement, or they have got a severe valve pathology. So if somebody's just got mild aortic stenosis, I wouldn't. But if they've got moderate aortic stenosis or mitral stenosis, I would recommend it. And these are the standard prescriptions for endocarditis, depending upon if you're penicillin allergic or not. Great. So in summary, Endocarditis, it remains a serious condition, and it does carry between 10 and 20% in hospital mortality. And it's a hard condition to diagnose. It's a very easy condition to say maybe the patient has endocarditis. It's a very, very much harder to rule out, having said maybe they've got endocarditis. And blood cultures are such a critical part of making that diagnosis. So they need 3 sets, ideally spread across time and from different locations. So maybe from one arm, from the other arm, from the back of the hand. Remember some red flags. So aortic valve endocarditis is a big red flag, because if the aortic valve falls apart, you get severe aortic regurgitation, and there's not a lot we can do to salvage the patient. If they go into cardiogenic shock with severe AR, they might respond to diuretics, but if they don't, we can't put in a balloon pump or do much else. We can end up in a position we can't salvage them. Whereas if it was mitral regurgitation, we could put in a balloon pump and that would get them out and get them to surgery. A rocking artificial valve is a very, very big concern, as are vegetations over 10 millimeters, Staph aureus, or any symptoms of heart failure. And just attention to detail when they're on the long course of antibiotics, because it is a bit frustrating and the patient often gets sick of being repeatedly attacked with Venflons. Do get a PICC line in early to make life easier. What's the ideal time between interval between taking each culture? That's I don't think there is an ideal time. If you've got 24 hours because the patient is presented very subacutely, then do it every 6 hours and potentially keep on going until you've got the blood culture back showing you something. If the patient's really sick, then maybe you've got 4 hours and you spread them over 4 hours. Maybe they're so sick that you need to get straight in and just do your 3 sets one after the other. But yeah, probably about 6 hours would be reasonable to spread it out. I have used as my background image this. Does anybody know what this is? And it's obviously topical. When you think endocarditis, this is something that you might be dimly aware of. So this is a famous unfinished symphony, and does anybody know who it was by? So this was Gustav Mahler, a famous composer, and he crossed continents to get his diagnosis of endocarditis. He had one of the very first blood cultures done, which confirmed that he had endocarditis, but it also confirmed that there was nothing that could be done about it because he lived before antibiotics were invented. So he died of endocarditis, but was one of the first people to be diagnosed with it. Wonderful. Thank you very much for listening. Any questions?